Okay, so now we're talking about cerebrovascular accidents, also known as a CVA. We're going to be looking at ischemic stroke and whether or not it is embolic or embolic. We're also going to be looking at hemorrhagic strokes and whether or not they are caused by aneurysms, hypertensions, or arterial venous malformation. Essentially, strokes are classified as ischemic or hemorrhagic and then subclassified. If it is an ischemic, it's from an occlusion or a blockage of a cerebral artery. Refer to figure 45-1 in your 8th edition or 47-1 in your 7th edition. Note that most strokes are ischemic in nature. An acute ischemic stroke either is thrombotic or embolic, meaning that the artery is occluded by either a thrombus, which is a clot, or an embolus, which is a dislodged clot. Hence the terminology thrombotic stroke or embolic stroke. A thrombotic stroke is responsible for more than half of all ischemic strokes and is commonly associated with atherosclerosis, usually occurring in the carotid arteries. Atherosclerosis occurs when plaque, made up of fat, cholesterol, calcium, and other substances, begins to build up inside the intracranial or the extracranial arteries. This happens over a period of time, and the plaque hardens, and it narrows the artery. A rupture of this plaque causes clot formations. If the clot is large enough, it causes an interruption of the blood flow to the brain, and this is what results in an occlusive stroke or a thrombotic stroke. This may be in the making for years due to the body's ability to compensate, with such as collateral circulation to the involved area developing. The most common sites of this are going to be in the bifurcation of the common carotid artery and the vertebral arteries, and their junction with the basilar artery. Thrombotic strokes are said to have a slow onset because of a gradual occlusion through the making of this plaque. Don't let that terminology fool you. This process may take merely minutes to hours, but saying that it has a slow onset is rather referring to the nature of the clot formation or plaque formation itself. Embolic stroke is caused by a thrombus or a group of thrombi which break loose and travel to the cerebral arteries through the carotid artery. The usual source of an emboli is in the heart or it's a plaque. The middle cerebral artery is most commonly involved in an embolic stroke, but emboli tend to become lodged in smaller cerebral blood vessels at the bifurcations or the narrowing of the lumen. The emboli lodges and it occludes the vessel. Ischemia develops and the patient presents as symptomatic for stroke. Now it is this occlusion that is causing all the problems. So if the embolus breaks into even smaller pieces, these fragments can then enter smaller blood vessels and be absorbed. So what we see is a sudden development, a rapid onset of neurologic deficits, and symptoms that may resolve within several hours to a few days. A stroke that starts out as an embolic stroke can also convert into a hemorrhagic stroke. This happens because of the ischemic damage that is sustained in the arterial vessel walls, and then the vessel becomes weakened and ruptures. When this happens, it causes bleeding to occur directly into the brain. A hemorrhagic stroke means that vessel integrity is interrupted or ruptured, bleeding is occurring either into the brain, intracerebral, or into the space surrounding the brain, subarachnoid. Intracerebral hemorrhage usually means that severe hypertension is causing bleeding into the brain tissue. It is the blood pressure that causes the changes in the arterial wall over time. When this changing in the arterial wall occurs, it makes the artery rupture more easily. Then there's damage to the brain from the bleeding, which is causing edema, distortion, and displacement. This type of stroke most often occurs due to a sudden and dramatic rise in the blood pressure. An example is that which accompanies cocaine abuse. Subarachnoid hemorrhage is bleeding into the space surrounding the brain. This is the space between the pia mater and the arachnoid layers of the meninges covering the brain. Usually, this is a cause of a ruptured aneurysm or from an arteriovenous malformation, which we're going to discuss a little bit more in detail. An aneurysm is an abnormal ballooning out in a weakened spot of an otherwise normal artery. The larger the balloon, the more likely it is to rupture. This causes the bleeding that occurs in the subarachnoid space, the ventricles, and or in the intracerebral tissue. This can cause the cerebral artery to then have spasms, which are called vasospasms. These are sudden and periodic in constrictions. Any tissue that's being supplied by this artery is then severely diminished, which leads to cerebral ischemia and infarction. A vasospasm is a condition in which blood vessels spasms lead to constriction. This constriction can then also lead to tissue ischemia and to tissue death or necrosis. The arteriovenous malformation, or AVM, is an uncommon abnormality that occurs in embryonic development. Figure 45-2 in your 8th edition or 7-2 in your 7th edition shows a tangled, thin-walled mass of dilated vessels that do not have a formed capillary network. These vessels will eventually rupture and bleed into the subarachnoid space or intracerebral tissue because of the buildup of arterial pressure that the capillary beds will normally lower. Capillary beds normally lower pressure between the arteries and the venous system, but the AVM does not have that. Modifiable versus non-modifiable. And then there's modifiable with treatment and modifiable with lifestyle risk factors. Chart 45-2 in your 8th edition or 7-2 in your 7th edition are the modifiable risk factors, and then there are the non-modifiable. The number of strokes occurring in our younger adult population is increasing, while the overall deaths that are related to strokes have decreased over the past 15 years. There's a direct association between strokes and drug use because many of the street drugs in use today cause hypercoagulability, spasms of the cerebral vessels, and hypertensive crisis. Some modifiable contributing factors include diet. It is a recommended diet change to include a high intake of fruits and vegetables with a low saturated fat content, cessation of smoking, drug abuse, especially cocaine, increases risk, excessive alcohol use, There are some studies that show a light to moderate alcohol consumption might actually decrease risk of stroke. Females using oral contraceptives are at risk, depending on how early the cycle begins, and also what type of oral contraceptive. Adding smoking as another contributing factor doubles this risk on oral contraceptives, and this risk then increases with age. Some antihistamine drugs will contain PPA, and the use of PPA that is consumed in these antihistamine drugs is a contributing factor to stroke. Pathological disorders. Atrial fibrillation is an independent risk factor for stroke. If the individual has atrial fib, it increases their risk factor about 5-fold. High blood pressure is the most important risk factor for stroke. These are just a few in addition to those on the slide. Remember, these are modifiable in that with treatment, the outcomes can be changed. These reference page numbers and tables are for the 8th edition of IGGI. Table 47.1, 47.3, and 47.4 would be your references in your 7th edition.